Now I'm very happy to introduce Professor Tokgozoglu. She is Professor of Cardiology at the Hacettepe University in Ankara. And of course, everybody knows her. She is a past president of the European Atherosclerosis Society. And I'm extremely happy and honored to have you today, Lale, to start our series. And Professor Tokgozoglu will speak about inflammation and cardiovascular disease. Lale, you have the floor.
Thank you so much for the invitation. It's a pleasure to be here among you. We know that atherosclerotic vascular disease continues to be the leading cause of morbidity and mortality worldwide, despite all our best efforts. And the most recent global burden of disease study has showed that it's increasing in middle-income countries. And unfortunately, there's an increase in women and younger people compared to previous years, probably because modern lifestyles lead to unhealthy behaviors and an epidemic of cardiometabolic syndrome. Now, atherosclerotic vascular disease is not a simple cholesterol storage disease. Yes, LDL cholesterol is extremely important, and without LDL, there would likely be no atherosclerosis. But it's actually a chronic immunoinflammatory disease that is triggered by risk factors, which triggers some sensors to give out mediators, which will have effects on the tissue. We have known for a long time that chronic inflammatory conditions like rheumatoid arthritis, lupus, predispose to atherosclerosis. But now we're increasingly learning that even for patients without any chronic inflammatory disease, there is a subclinical inflammation leading to atherosclerosis. All the risk factors we know contribute to LDL storage because endothelial permeability changes, lesion growth because of all the cytokines, and plaque rupture because of also several mediators due to subclinical inflammation. First, innate immunity is triggered in atherosclerosis, where several cytokines, growth hormones are released, and they contribute to LDL accumulation and growth of the plaque. But the T cells that are patrolling the vasculature, when they see ApoB-containing lipoproteins, they perceive it as an antigen, and as a second part, there's a T and B cell response, so cellular immunity is also triggered, and all of this exacerbates the atherosclerotic process. And inflammation eventually leads to thinning of the fibrous cap, with the matrix metalloproteases and decreased collagen synthesis, and the plaque rupture leads to thrombus and acute coronary syndromes. Now, we know that the NLRP3 signaling complex that is triggered by risk factors is an important role player in this whole subclinical inflammatory process. And the ongoing chronic inflammation caused by the NLRP3 inflammasome is a major contributor to the risk of cardiovascular disease. Once triggered, the caspase enzyme cleaves pro-interleukin-1 beta and 18 to interleukin-1 and 18. Interleukin-1 induces more interleukin-1 and interleukin-6, which then leads to an acute phase response in the liver with elevations of CRP, fibrinogen, and others. And we can measure actually this acute phase response. We know that CRP is just an end product, but there is more and more evidence making us think that interleukin-6 can actually be pro-atherogenic. So how do we diagnose this chronic inflammation going on in atherosclerosis, and what is the best biomarker is a question we clinicians like to ask. We know that there is a linear relationship between high sensitivity CRP levels and risk of future cardiovascular events. Here in blue, you see the relationship, and when you correct for risk factors, the relationship is slightly attenuated, but still there. So high-sensitivity CRP levels between 1 and 3 will show moderate and above 3 higher risk patients. However, CRP increases also during infections. So if it's about 10 milligrams per liter, then this is not probably subclinical atherosclerosis and an acute infection is ongoing in this patient. Serial measurements of high-sensitivity CRP levels demonstrate quite a well long-term sustainability. So when you look at the distribution over time, they are quite similar to LDL cholesterol variations. So unless there is a new infection going on, they are pretty stable within the individual. We have known for a long time that in secondary prevention trials, the residual inflammatory risk was an important predictor of cardiovascular events, together with LDL cholesterol. We have seen this in the Prove It, Trim It trial, as well as the Improve It trials, showing that patients with the highest LDL and CRP are the most likely to have recurrent events. More recent information is coming from primary prevention trials. In about 30,000 initially healthy US women, high-sensitivity CRP, LDL cholesterol, and Lp(a) were measured at baseline, and at 30 years, they were able to predict the risk of a first major cardiovascular event. The higher the CRP or Lp(a) or LDL, the higher was the risk. They were both individually predictive and when combined, predictive of having a cardiovascular event. You may say that this is just for US women, but similar findings have been seen in Europeans in about 9,000 women and 7,000 men. And this was the EPIC-Norfolk study. Universal one-time screening for these 3 parameters showed cardiovascular risk, and the lines were almost very similar to the US study, showing that these 3 important biomarkers can predict risk both in men and women. There's also a recent publication looking at C-reactive protein and cardiovascular risk among women who did not have the classical standard modifiable risk factors. In this NIH-funded women's health study, levels of high-sensitivity CRP was measured at baseline, and then at 30-year follow-up, cardiovascular events were determined. And here you see that in these 12,000 women who did not have conventional risk factors, having a high-sensitivity CRP above 3 milligrams per liter predicted events. This was similar to the Jupiter study, where CRP predicted events, and giving a statin decreased this. So maybe since these patients are at increased lifetime risk for atherosclerosis, they may also benefit from statin therapy like the Jupiter trial. We recently looked at the UK Biobank in about 500,000 adults, looking at CRP levels below 1, 1 to 3, or above 3, and showed that the highest CRP level tertile was the group of patients who were at highest risk of cardiovascular events, with a median follow-up of 13 years. And we recently published this in the European Heart Journal together with the Aachen group. So high-sensitivity CRP independently predicts cardiovascular events and adds incremental value to SCORE2-based risk stratification. So in individuals without atherosclerotic vascular disease, it is a clinically relevant predictor of risk, supporting the measurement of high-sensitivity CRP for risk assessment in primary prevention as well. What about interleukin-6? Now, interleukin-6 is thought to be pro-atherogenic because when you look at Mendelian randomization studies, genetic perturbation mimicking interleukin-6 is associated with cardiometabolic risk. So if a patient has genetically downregulated interleukin-6 signaling, the risk of coronary artery disease, peripheral arterial disease, and ischemic stroke is less than average patients. So this is one clue saying that IL-6 may be proatherogenic. Another clue comes from animal studies. Atherogenic mice who have increased interleukin-6 production treated with an anti-interleukin-6 antibody have shown decreased atherosclerosis, suggesting a causal role of interleukin-6 signaling in the development of atherosclerosis. We also looked at interleukin-6 in the UK Biobank in about 50,000 adults, showing that those with the highest quartiles were more likely to have cardiovascular events within a follow-up of 15 years. And it was ranking above most of the traditional risk factors in predicting risk. So there's more data for you showing these biomarkers to predict cardiovascular risk, even in primary prevention. What about imaging markers? In addition to biomarkers, there are some new techniques that can show us inflammation in the arterial wall. Now, positron emission tomography and MRI have been the gold standard for inflammation, but because of lack of clinical expertise and availability outside major centers, they're not being used for the purpose of detecting inflammation in the arteries, only maybe for research. But new techniques with computed tomography can help us show inflammation in the plaque. A new indicator of inflammation is the fat attenuation index. We know that vascular inflammation triggers characteristic changes in the texture and composition of perivascular fat, and recently, with new technology, perivascular fat attenuation index has been possible to be measured by CT angiograms. The Oxford group is leading this research, and they asked the study, does coronary inflammation predict future cardiovascular events? So in the orphan study, they looked at consecutive patients undergoing CT angiography in the USA and calculated these scores. And the fat attenuation index score was an important predictor of events, more so in patients who do not already have obstructive coronary artery disease, but also to a lesser extent in patients who do have obstructive coronary artery disease. An interesting study from Brittany Weber looked at inflammatory risk quantification, this time in patients who already have systemic inflammatory diseases like lupus, rheumatoid arthritis, or psoriasis, and showed that if the fat attenuation index was decreased, then these patients had more significant cardiovascular events at follow-up. So this is also important information showing that inflammation on imaging can predict events. So how do we manage this chronic subclinical inflammation to prevent atherosclerotic vascular disease? All this information is good, but what about clinical practice? So we first have to decide, is inflammation friend or foe in cardiovascular disease? I like to see inflammation as a well-orchestrated response to repair and protect tissue integrity against different threats. So it's like a big orchestra. If we get rid of the whole orchestra, then we will be defenseless against all these threats, plus the repair function will go away as well. But when inflammation does not resolve, we know that it can lead to chronic diseases. So we have to be very selective in what we block and what we do not block. When we look at inflammation in cardiovascular disease, there's the good part, the protection and healing. For example, after an acute myocardial infarction, there is some healing. That is why in the past, when we use steroids or non-steroidal anti-inflammatory agents during a myocardial infarction, they were harmful. But there is also the bad residual low-grade inflammation that we want to target. And this is being targeted by several studies. And there's the ugly acute burst of inflammation that we see during reperfusion injury. So we have to be selective in targeting which part of inflammatory process we are trying to block. How do we cause an anti-inflammatory system in us? Lifestyle is important. We've known for a long time that Mediterranean diet, exercise, non-smoking, and maintaining a healthy weight are anti-inflammatory. So we have to make sure all of our patients are doing this. We're also having some non-targeted therapies. So these therapies are given for another purpose, but they're able to decrease inflammation a little bit, not completely, but a little bit. Here you see the typical recommendations for a healthy lifestyle. This is from the prevention guidelines of the European Society of Cardiology. So these are all the Mediterranean type diets, plus low processed foods and increase in fish, which are all anti-inflammatory. What are the non-targeted therapies? Statins, GLP-1 receptor agonists, SGLT inhibitors, bempedoic acid, and icosapent-ethyl have all shown to decrease CRP to a small extent, but the anti-inflammatory pleiotropic effect is there. Also, surprisingly, some of the drugs we use in the treatment of heart failure, such as renin-angiotensin blockers, ARNI, do have anti-inflammatory effects. The effect of lipid-lowering therapies on CRP levels has been tested in a large meta-analysis, showing that regardless of the LDL reduction, the medications I mentioned, like statins, bempedoic acid, ezetimibe, etc., reduce LDL CRP levels, and CRP reduction is higher in those with baseline higher CRP levels. But despite using statins or ezetimibe or PCSK9 inhibitors, there is still some residual inflammatory risk. So these current non-targeted therapies are all helpful, but they do not completely eliminate the risk of inflammation. For this, we need targeted therapies that suppress inflammation, but we do not want to affect the repair and immunity systems. For example, TNF blockers did more harm than good because they were blocking both the good and the bad part of the inflammatory system. So most of these efforts today are concentrated on blocking the NLRP inflammasome and trying to block the cellular immune response to a lower extent. Several different pathways have been therapeutically targeted, and this is a very nice review from the European Heart Journal Cardiovascular Pharmacotherapy, showing that which pathways have been targeted. So interleukin-1, 6, complement 5, and several systemic anti-inflammatory pathways have been targeted for this purpose. The NLRP inflammasome is the major target these days, and it can be targeted at different levels. Colchicine can stop the microtubule polymerization from the very beginning. And there are also interleukin-1, interleukin-18, and 6 inhibitors that have been tested for this purpose. But there have been 3 major randomized controlled trials testing targeted inflammatory therapies because the rest have been all very small trials. So these 3 agents are canakinumab, which is a human anti-interleukin-1 beta monoclonal antibody, which has been approved for several different rheumatological diseases. There's colchicine, which we also use for several different purposes, like gout, FMF, and pericarditis, and has the advantage of being low cost. And methotrexate, which is a folic acid antagonist and is known, has been used for other rheumatological diseases. Low-dose methotrexate for the prevention of atherosclerosis was tested in the CIRT study in about 5,000 patients with prior MI or multi-vessel disease. These patients received methotrexate in low dose weekly or placebo. Unfortunately, methotrexate did not result in lower levels of interleukin-6 or CRP and had no effects on cardiovascular outcomes. That was one negative trial. Then came the CANTOS trial, and this was the first randomized control study to prove that inflammation is causal in cardiovascular disease. This was done in stable patients with coronary artery disease with elevated high-sensitivity CRP levels above 2 milligrams per liter. And the primary endpoint was non-fatal MI, stroke, or cardiovascular death. In the end of the study, there was a significant reduction of inflammatory biomarkers like high-sensitivity CRP and interleukin-6. The classical risk factors, lipid factors, blood pressure did not change. And when we look at MACE and MACE plus, there were about 35 to 40% reductions in inflammatory markers and a significant decrease in cardiovascular events in those who used canakinumab. There was greater risk reduction with greater cytokine inhibition. So those who really lowered their high-sensitivity CRP on treatment, there was even a 36% reduction in cardiovascular events. Because of increase in infections, this drug was not proceeded further for cardiovascular prevention, but it gave us good information about the advantage of lowering inflammation in these patients. And this study also showed that in chronic kidney patients, chronic kidney disease patients, inflammation is a more important predictor of events than LDL cholesterol. Then came the colchicine trials. Low-dose colchicine was tested in the LODOCO trial in about 5,000 patients with coronary artery disease, showing a significant reduction in cardiovascular events. The 4-point MACE was decreased by 31%. There was a non-significant increase in non-cardiovascular death, but it was not due to an increase in particular infection or cancer. In COLCO trial, this time, low-dose colchicine was evaluated in patients within a history of MI within 30 days of enrollment. And here again, there was a significant decrease in cardiovascular events. MACE was decreased by 23%. So all was going well for colchicine, and it was being integrated in the guidelines. But then the clear synergy study came. This time in 7,000 adults, patients were enrolled acutely within 72 hours of a PCI for an acute coronary syndrome. And you see here that the trial was completely negative. There were lots of explanations being put forward. There was not enough time for the inflammatory process targeted by colchicine to develop because it was in acute patients. COVID pandemic has an impact. Before COVID, things were going well and the curves being separated, but afterwards there was a problem. And there was higher incidence of diarrhea, so there was some non-adherence. Nevertheless, this trial was negative for colchicine. There is also a new imaging trial called the Ekstrom trial in a small number of patients. When these patients were given colchicine, there was a significant reduction in total plaque burden and dense calcified plaque. So imaging also seems to support colchicine use in chronic coronary syndrome patients. So when we look at colchicine for long-term secondary prevention of vascular events, there are the three big randomized trials that I told you about. You are seeing that Colcoat, COPS, Lodoco being positive and CLEAR being negative. And the meta-analysis, which also included CLEAR with the negative results, favored decrease of MACE by 12% in these patients. Now, there's also new drugs being tested that are downstream inhibiting interleukin-6. Ziltivekimab is a fully human monoclonal antibody against the interleukin-6 ligand, and it can be administered once a month subcutaneously. It has been shown to reduce markers of systemic inflammation. In the rescue phase 2 trial with ziltivekimab, there was up to 90% reductions of high sensitivity CRP compared to placebo with this agent. And in the phase 2 trial, it seemed to be safe in terms of adverse events, safer than canakinumab. So now there are three large cardiovascular outcome trials with ziltivekimab. ZEUS looking at patients with atherosclerotic vascular disease and chronic kidney disease, already finished enrolling trials. HERMES for patients with heart failure and reduced ejection, preserved ejection fraction, and Artemis trial in patients with acute MI. So when these trials end, we're going to have a lot more information about inflammation inhibition. There are also several other trials that have been done in small numbers with different agents, but so far canakinumab and colchicine trials were the only positive ones. And also there are several trials at preclinical stages looking at different phases of inflammation to see whether we can block it without completely blocking the repair and immunity process. There's a recent trial, very recently published, with interleukin-2 inhibition in acute coronary syndromes. This was an imaging study showing that FDG inflammation was less in patients who got the interleukin-2. So lots of new data is emerging according to different anti-inflammatory therapies. But as a clinician, we have to go with the guidelines. So what do recent guidelines recommend? In the most recent update of the European Dyslipidemia guidelines, we recommended that high sensitivity CRP above 2 milligrams per liter is a risk modifier and can upgrade the risk of the patient above that we calculate from the score 2. And in the 2024 chronic coronary syndrome guideline, in chronic coronary syndromes, low-dose colchicine should be considered to reduce cardiovascular events. This is a class 2A recommendation. Very recently, last month, American College of Cardiology issued a new scientific statement on inflammation and cardiovascular disease. And compared to Europeans, they were a little more, they expanded the indications more. Because clinicians will not treat what they do not measure, they are recommending universal high-sensitivity CRP screening, both in primary and secondary prevention, not recommending screening for other inflammatory biomarkers, and both for primary and secondary prevention, saying that high-sensitivity CRP is an important risk predictor, and recommending low-dose colchicine for patients with chronic stable atherosclerosis. So these are their recommendations that came out recently. In conclusion, I would like to say that lowering LDL cholesterol and controlling the traditional risk factors should always be our primary goal, because these are the triggers. So we have to get rid of the triggers of inflammation before we suppress the inflammation. But now we're learning that inflammation is not only a pillar related to cardiovascular events, but maybe a therapeutic target. And targeted anti-inflammatory therapies are reducing high-sensitivity CRP and interleukin-6 levels to levels we have not seen before with non-targeted therapies. And the ongoing studies will reveal which patients will benefit best from which anti-inflammatory therapy and its impact on cardiovascular outcomes. So I would like to stop here. Thank you very much for listening to me, and I will be happy to take any questions you may have. Thank you.
Well, thank you so much for this excellent talk. I'm looking at the chat to see if there are questions. If not, we have. So I start with Adele, and then I will continue with my questions. I read what the colleague is writing. Why don't we use natural substances with anti-inflammatory effects like omega-3 regularly, which precede a positive effect, for example, in the EVAPORATE trial? And she has a list of the positive effects: modulation of lipid oxidation, improving endothelial function, reducing recruiting of inflammation cells, inhibits production of inflammation mediators, prohibits platelet aggregation. What do you think, Lale, about this point of the colleague?
I think that high-dose icosapent ethyl has proven itself over and over. In the EVAPORATE trial, it decreased the content of plaques. And more importantly, in the REDUCE-IT trial, reduced cardiovascular events by 25%. But it is a medication that is very expensive and not available all over. The guidelines are recommending high-dose icosapent in patients at high risk who are statin treated but still have high triglycerides. So that is classical knowledge from the guidelines. Now, when we try to reproduce the results with IPE-DHA combination, other types of omega-3 fatty acids, or low-dose omega-3 fatty acids, unfortunately and surprisingly maybe, there was no reduction in cardiovascular events. And all the low-dose vitamin supplementation omega-3 trials up to this date failed to reduce cardiovascular events. So taking a natural omega-3 by eating more fish, Mediterranean diet seems to work, but for some reason, supplementing omega-3 fatty acids that are available widely and are much cheaper is not working. But high-dose icosapent ethyl for a specific group patients is already recommended in the guidelines.
And do you have any idea why this, when you give EPA alone, it's like working, but if it is docosa, hexanoic acid with it, then it just doesn't work? I cannot figure out why. Do you have any hypothesis? Or?
There are several hypotheses, non-proven. One of them says that DHA actually counteracts some of the effects of EPA. And the others are saying that when you combine, you cannot go to the higher dose of EPA. So you have to synthesize it so that it's at very high dose. There are several other explanations, their effects on the membranes in the cell, etc., none of which have been proven. It would have been very nice if those trials were positive, because then we could give easily available supplements to patients. But there were two OMEMI trials and strength trials, both negative in a large number of patients, and they were randomized trials. We have to go by randomized trial data. So yes, the basic science is supporting, but we need some trials to prove it works.
Very, very good point. I think I will not have the time to ask my questions, which is excellent. I like the colleagues to ask the questions. Mr. Dababo, then in patients with CCS, do we need to start colchicine for everyone? Is this correct?
This is a very good point. And since the answer is not clear, last year in the European Society of Cardiology Congress, we had a debate. Should all CCS patients get colchicine low dose, or should only those with recurrent events get it? But the debate was, should we measure CRP, and if it's high, then give colchicine? So unfortunately, the trials are not giving us a good answer related to this, because in the colchicine trials, most of the patients did not get a baseline CRP measurement before being enrolled. So in the Lodoco, there were only 200 patients who had their CRP measured. In the other one, none of them. So the guideline is giving it as a class 2 recommendation, which is you should consider it, but it's not like class 1 where everyone should get it. One way to do it is look at high sensitivity CRP, and if it's high, then give it, which was the approach taken by Professor Paul Ridker when he recommended in the debate. And the other opponent said that you should give it to everyone. So what do I do in my clinical practice? And this is not the guideline, but what I do, because I see a lot of patients, is that if we're not able to control obesity, some other risk factors of the patient, although we give the standard therapies, if the patient has recurrent events, or if the CRP is elevated, and I try to look at it, mostly because I'm also enrolling for trials, but I do like to look at CRP. And if it's elevated, I do give it. But as of today, I'm not giving it for everyone. But the guideline says you should consider it for everyone, then leaving it to the clinician to make the decision.
And do the patients tolerate this well?
Because it's low dose, it's okay. In the beginning, they do tend to get a little diarrhea. But when we treat, for example, pericarditis patients with a higher dose, they're more likely to get diarrhea. One word of caution is chronic kidney disease. If the GFR is below a certain extent, below 30 or so, we should not give it. And there are also some drug-drug interactions. So if the newer agents like ziltivekimab, etc., turn out to have positive effects, they will probably be better because they will not have the chronic kidney disease limitation. Actually, they're good for chronic kidney disease. Plus, they will not have the diarrhea side effects. But colchicine is available and cheap now, and the lower doses are quite well tolerated.
Perfect. So Konstantin is asking, so in patients classified as low risk by the SCORE2 calculator, but with persistently elevated high sensitivity CRP and no other conventional risk factors, what would be the next therapeutic steps? So low risk, but persistently elevated this enriching factor. How do you do with these patients, Lale?
First of all, a SCORE calculates only 10-year risk, and we should be thinking about high lifetime risk. One advantage of the prevent risk calculator that is used in the United States now is it looks at renal outcomes and more into cardiorenal metabolic syndrome in a way. So it may predict better for longer term risk, and it calculates risk up to 30 years. But of course, in Europe, we can't use it because the risk calculators are validated only in the populations they're going to be used at. So if the patient is intermediate risk and having high sensitivity CRP, I would consider giving a statin and upgrade the risk category a little bit. But if the patient is very low risk, then I would like to look at other risk enhancers to see if this patient is going to benefit from low-dose colchicine, because you don't want to give forever to a very young patient anti-inflammatory therapies. So I may do some imaging to see if the calcium score is non-zero. I would like to ask family history of disease, even if the patient is Smurfless. and always look at LDL and Lp(a) as well to make this informed decision. But for intermediate risk patients, the informed decision is easier because they may be upgraded to a higher risk and they may have subclinical atherosclerosis. The concepts are changing, and now it's blurring primary and secondary prevention after the Vesalius trial. So we really need good markers of subclinical atherosclerosis to be able to decide.
Excellent. I had there are so many papers recently discussing that if you have high sensitivity CRP that is high Lp(a) and LDL, this is like the big bad whammy. From all this, let's say LDL, in your opinion, is the highest, the most important risk factor. How do you rate these other two, Lp(a) versus high sensitivity CRP?
For example, the women's health study, CRP was the best predictor, surprisingly, compared to the others. But let's put things into perspective. I mean, you need to have LDL accumulation to have atherosclerosis. If a patient has loss of function in the PCSK9 gene, no matter what other risk factors they have, their likelihood of developing disease is very low. So I think LDL is essential and is actually the trigger of inflammation. So I would rate that number one, and the guidelines are putting that number one as well. Lp(a) per se is maybe 6 times more atherogenic than LDL, but it's not that high in everyone, and you need to have certain levels after which you start getting risk of disease. So I would say that is also very pro-atherogenic, and it will be taken into consideration more and more in the future, especially if you have specific therapies that work for it. And CRP is a reaction to maybe both of them. There are also papers showing that the coexistence of high-sensitivity CRP and Lp(a) are required for Lp(a) to work. There are others that contradict it as well. But I think that it's a very interrelated thing. But I would go for the triggers first and then the inflammation. So most groups in the USA are recommending that maybe in the future we take LDL all the way down, the statins, PCSK9 inhibitors, and then add an anti-inflammatory. So I would still say that LDL is king, or let's say queen.
Okay, and Lp(a) is also pro-inflammatory. Do you believe that? I mean, I have patients with extremely high Lp(a), and they have nothing, and they are like 70 years old. Do you think that they simply don't have oxidized phospholipids on Lp(a)? How do you explain? I mean, this is not directly the inflammation, but Lp(a) is pro-inflammatory. So do you have an explanation why some people have one event after the other with only Lp(a) being there, and others have 300 milligrams per deciliter, they're 70 years old, and don't have anything?
That is a concept we're trying to understand. I mean, when you look at population, epidemiological studies are easier to interpret. Look at the Copenhagen study. If your Lp(a) is above a certain quartile, you are much more likely to have cardiovascular disease, but it's not a guarantee, it's likely to have. So when you look at the personalized levels, you have to think of all the vulnerability genes and the protective genes. And we do not understand the protective genes as well. In South Africa, for example, there are also patients with very high Lp(a), not any cardiovascular event. So I think it's all an interaction of several things. Inflammation may be one of the parameters, that is, those who have a pro-inflammatory response to LDL and Lp(a) are more likely to have the disease than others. But there's a lot we don't know today. So I don't have a specific explanation, although I do have patients like that as well.
Okay, let's see, before I monopolize you, if we have more questions in the chat. No, so then I will pick your brain with other things. Yeah, exactly. I scribbled it so I couldn't even read my handwriting. Do you think that high sensitivity CRP will ever make it to the score as a part of the score calculator?
I doubt it because development of score 1 and score 2 took several years and in thousands of patients was first calculated, calibrated, and then validated in millions. So for that to go into the score system, you need a lot of patients who have already had their CRP measurements. And it shouldn't be a selective group like the UK Biobank. You have to have in the general population huge amount of database with patients high sensitivity CRP measured, and then put it in the calculation to see how much it reclassifies, etc. So I don't think in the near future, but if CRP is universally measured, like in the US, the ACC guidelines recommend, then they will have a large database of CRP measured patients, after which they can recalibrate their calculations. So I think it's a huge effort to be able to do a risk calculator. And you need a lot of data for it. UK Biobank is a selective group of patients with selective ethnicity.
That's a good one. And do you think, I mean, I always thought that maybe now, or I mean, not now, but in the near future, Lp(a) may make it to a score?
You need the same answer for that one. But we are strongly recommending universal Lp(a) screening in the guideline already, although we're not recommending it universally for CRP, in the European guidelines at least. Yeah. So I think that if targeted Lp(a) therapies are coming out, more people will definitely measure it. And same goes for anti-inflammatory therapies. These trials will end later than the Lp(a) trials, but once they end, if they're positive, then people will really universally start screening, and then you will have data, and then you may be able to put that in the standard risk calculation systems.
Just 1 second, because I think we have another audience question. Oh, we have a very interesting 2 questions. Does low dose, so this is from Jonathan Mambair, does low dose prednisolone therapy, less than 10 milligram per day in COPD patients, so any clinical benefits in COPD, coronary heart disease, comorbidity, and or lowering high sensitivity CRP and interleukin-6? So if you have COPD and you're getting prednisolone, was it ever examined if this decreases interleukin-6 and comorbidities like cardiovascular risk?
Because it's going to increase other risks, steroids are to be avoided, I think, for this purpose. They've been tested in acute myocardial infarction settings, and there were more myocardial ruptures and complications with steroids during the ACS setting. And in chronic disease patients, all the rheumatologists are trying to get away from giving steroids and coming up with new monoclonal antibodies every day that are more targeted and do not have off-target toxicity. So I don't think that it will be a pure study, because you're going to get the negative effects of the steroid, which will override the positive effects, if any. So I don't think so.
Good point. Is there a correlation between fatty liver disease, insulin resistance, and high sensitivity CRP?
Yes, definitely. So the cardio-kidney metabolic syndrome is a disease where organs talk to each other, and the common theme is subclinical inflammation. So its components are chronic kidney disease, eventually progressing to renal failure. First, subclinical atherosclerosis and heart failure with preserved ejection fraction, then all of them becoming overt disease, and several other components. Usually obesity or overweight or insulin resistance are the drivers, but this starts a cascade of pro-inflammatory events which eventually lead to disease. So yes, definitely that is one component. And recently, GLP-1 receptor agonists have been tested in MASH, showing that they do decrease the liver fat, the inflammatory markers, as well as cardiovascular disease. So yes, there is a connection there, and inflammation seems to be the common theme overarching theme for all of these diseases.
And another one just came from Jakob. How do you treat very high-risk patients with elevated high-sensitivity CRP or Lp(a)? Do you set the LDL cholesterol goal at less than 55 milligrams per deciliter, as in other very high-risk patients, without those modifiers, or lower, it's very aggressive, or lower LDL cholesterol to less than 40 milligrams per deciliter?
For very high-risk patients, the guideline recommended goal is below 55 milligrams per deciliter. For now, we have slight evidence, class 2 evidence, showing that to go below 40, to recommend it below 40, you need to have a patient with either recurrent events on lipid-lowering therapy or polyvascular disease, where both the carotids and the coronary or peripheral disease is there. Now, having a high sensitivity CRP will likelihood increase the extent of atherosclerosis in these patients. And we know that there is no threshold below which cardiovascular side effects increase. So there's no J curve with LDL lowering. And if we think that the patient is at a very high risk, we should go as low as possible unless the patient is experiencing side effects. So going below 55 is a must. And if you're able to go lower, you can do that if you think that the patient is at very high risk. But you have to make sure of safety first and whether the patient is tolerating these drugs.
So I think what he meant is if you have a very high-risk patient and you have also high Lp(a), do you automatically make him extremely high risk?
Not according to the guidelines, but evidence is suggesting that maybe we should be doing it. Now, when we look at the Lp(a) consensus of the European Atherosclerosis Society, there, Professor Brian Perez did a lifetime risk calculator. First taking into account the classical risk factors and then adding Lp(a), which shows a significantly increased risk when you take high Lp(a). So the risk conferred by Lp(a) depends on both the baseline classical risk factors and the Lp(a). If both are high, the risk conferred by Lp(a) is going to be like 3 times higher than the original risk that is calculated, which is when you should think about taking LDL to lower levels. The recent US guideline is recommending that if a patient has high Lp(a), this is a reason to use PCSK9 inhibitors, even if you were not already using them and you are at goal. So the answer is not a straightforward yes, but yes, probably we will have to think about it. It all depends on the patient, but the risk is going to be significantly higher, so we should go lower, although the European guidelines are not yet recommending it.
I was very surprised with the American guidelines where I read this PCSK9. I found it not really based on data. Of course, it's not a 1A recommendation. But
I think the data, it's the Family Heart Foundation study looked at a lot of patients who had atherosclerosis and looked at Lp(a) and showed that in a subgroup analysis, those who got PCSK9 inhibitors compared to those who got statins alone did better. So I think they're basing it on that data, but not a randomized trial or anything.
I will ask you one last question because we have you here and I want to pick your brain as much as you can. It's not directly, if you could, with three sentences, focus on the three things that you found differing and interesting between the European guidelines and the just published American guidelines. Are there a couple of things that you said, wow, this is weird, or we agree on that, or
actually, we just had
wrong?
a debate about it in Ljubljana in Europrint 3 days ago. So, first of all, very happy to say that they are much closer to each other now and getting harmonized. In acute coronary syndromes for patients, we recommend upfront combination therapy in the European guidelines, whereas in the US guidelines, it's still a stepwise approach. 2, they're using the PREVENT equation, which has the cardiokidney metabolic stuff incorporated in it, plus it predicts 30-year risk. So that is a good advantage for their population. It also has the social disability integrated in their risk stratification. So that is a difference from us. They're also recommending universal Lp(a). They are finally back to goals with us. Their goal recommendation of below 55 is optional, whereas we make it as strictly recommended for very high-risk patients. So there are small nuances in the PCSK9 stuff you just mentioned, but otherwise they have become much more similar. And when the chair of the US guidelines was in this meeting, she said, I hope this will be the last session where we talk about differences between the guidelines, and now we can say that they are similar. So that was the general take-home message of that session at EuroPrevent.
Wonderful. So, Professor Tokgozoglu, dear Lale, thank you so much for this wonderful hour that we spent together. It was a wonderful talk. I learned a lot. I hope the audience, I want to thank the audience, of course, also for joining us. And yeah, thanks again. And I'm sure we will see you soon on another topic. Thank you, everybody. Have a great evening.
Thank you very much for the invitation. Bye.